Welcome, everyone. I'm Allitia DiBernardo with Janssen & Janssen Innovative Medicines, and we're here broadcasting live from the AANEM Congress in Phoenix, Arizona. We are here at the Congress, which is one of the most important neuromuscular congresses, really to support the scientific exchange and dialogue here around neuromuscular diseases with, I think at this point, over 20 presentations, scientific presentations, including something I'm very personally proud of, the first time that we have had a patient-authored and patient-presented scientific poster. We have also supported talks with really world-class leaders in neuromuscular medicine, like my guest, Dr. Beydoun, who I will introduce momentarily. We're here right now to talk about myasthenia gravis. Dr. Beydoun is actually the professor and neuromuscular division chair at the Department of Neurology at the Keck School of Medicine, University of Southern California. Thank you so much for being with us.
My pleasure. My pleasure. Yeah. Thank you.
And I'm looking forward to our discussion on myasthenia gravis, which I know is a topic that is very near and dear to your heart.
Correct.
So my first question, Dr. Beydoun, is just tell us a little bit more about the history of myasthenia gravis and things that we have learned that we didn't know even 5, 10, 15 years ago.
Yeah, that's really great because the history of myasthenia gravis is very fascinating, and the learning curve that has accelerated in the last decade has been quite breakthrough and revolutionary. But I've talked about the history going back to 1672. Oxford physician by the name of Thomas Willis described a unique case of a patient under his care who had symptoms of weakness and speech and swallowing. And even if you read the original text, which was in Latin, and that's why it was unrecognized until 1903, that describing that he is a prudent woman under his care who cannot was able to speak hastily and until a point where she lost the ability to speak, becoming as mute as a fish, and took her 1 to 2 hours for recovery. Then 200 years elapsed, and Samuel Wilkes in London described a case also that looked like myasthenia, although it was not termed myasthenia, but bulbar paralysis. In the discussion, he discounted hysteria as a possible etiology, but pondered what it could be. And during that era, in the late 1800s, German physician, Polish physicians started to pick up on this. Dr. Goldflam and Herbs describing 3 cases of bulbar paralysis, and then Jolly in 1895 said this is used the term myasthenia gravis pseudoparalytica, which is a Latin word and a Greek word combined, and describing the classical manifestation of myasthenia. Relation between myasthenia and the thymus began to be known in 1901, describing a person with myasthenia had a thymic tumor by Dr. Carl Weigert. And really, in terms of therapeutics, until 1934, a physician by the name of Mary Walker, who was a physician in Greenwich, London, and was presenting a case to Dr. Danny Brown, who was a visiting professor from the US. And he told her, well, that reminds me of curare poisoning. And that generated some intellectual curiosity in her. Tried physostigmine on that patient. It worked remarkably well. Second patient, she tried prostigmine. And so this is how cholinesterase inhibitor began to be used in myasthenia gravis and are, until now, the main symptomatic treatment option and our first line of treatment. In the 1950s, steroids were introduced, but did not really were used correctly because of issues with high dose and crisis and tailoring and tapering. In the 70s, they began to be used more. And during that time, also immunosuppressive medications start to get used in plasma exchange, IVIG in the mid-80s. And in 2000, B-cell depletion therapy started to be known as helping patients with myasthenia gravis. And now we know it helped a subset of patients with myasthenia gravis with a different pathogenesis than either the classical AChR antibody myasthenia. 2013, the first clinical trial of complement blockers were initiated, approved in the US 2017, and FcRn blocker approval in late 2021, and the flurry of clinical trials evolving and with multiple FcRn blockers and complement blocker and different mode of administration. So, fascinating history.
Really fascinating. It sounds like science has been kind of accelerating and really revealing a lot of insights, including treatable targets, drug targets. I'm just curious about the name. It's such a unusual disease name, myasthenia gravis. Does it mean severe muscle weakness?
Myasthenia is muscle weakness,
Yeah.
so gravis is serious.
Yeah,
so myasthenia is a Greek word, and then gravis a Latin word. So it's really, and because myasthenia early on, it was mortality was so high, almost 100%.
Yeah.
Patient, until many developments happen with the use of negative pressure ventilation, antibiotic, cholinesterase inhibitors, then positive pressure ventilation and ICU medicine, and the newer agents, the immunotherapeutic agents.
Yeah.
Starting from corticosteroids being the first to be used.
Yeah. And I was also struck in your history that some of the earliest descriptions seemed like they were related to bulbar manifestations.
Yes.
And is that a subtype of myasthenia gravis?
So this is one of the most important symptom in patients with myasthenia. Although the majority of patients with myasthenia at presentation are ocular, and 50% are purely ocular at the onset. Of those who present as generalized, even 85% have ocular symptoms. And but then as the disease evolves, other muscles tend to be affected: speech, swallowing, respiration, limb weakness, neck muscle weakness. Characteristic selectivity of muscle weakness is so unusual in myasthenia gravis. We all know, like, neck extensor weakness is very characteristic. As patients get weak, they develop like a neck drop, and they have to hold their chin to keep their head straight. Or they develop, a masseter weakness, so they have to hold their chin so that they'll be able to chew, or not their jaw to drop.
Yeah.
So and bulbar symptoms, speech, swallowing, sometimes drives those patients initially to visit an ENT physician, thinking it's something that has to do with the swallowing. They undergo GI studies and examination of their vocal cord, and these really are part and parcel of symptom myasthenia, and we capture them in many of the outcome disability scale and physical examination scales to follow patients with myasthenia.
And you mentioned ocular, which is also, I think, an important subcategory of myasthenia gravis. What are the symptoms? Are we talking about a decrease in visual acuity? What does that mean, optical?
So ocular is really involve few muscles, like eye closure muscles, the drooping of the eyelid, which can be very paradoxical and asymmetric. That's, again, these are the same muscles innervated equally, and the same antibody, but one manifests. So asymmetric ptosis, which is droopiness of the eyelid, that's fluctuating, and eye motility symptoms. These are the extraocular muscles, and they can get double vision. It's horizontal, vertical, it's binocular diplopia, and can happen at any time during the day. It's very unpredictable. Typically with more strain, the more they use their eyes, but can be for no reason. Again, these are the ocular symptoms that patients very fluctuating.
And I imagine that's very disability. It's a real disability to not be able to focus on your computer screen or on the road if you're driving.
Exactly. I mean, again, even though, like, when now we're using new treatment, and new treatment are being approved for generalized myasthenia, we tend to forget about those purely ocular, because about 20% of patients with ocular presentation remain ocular. They do not generalize. And these patients could be, high-level professional or any ordinary person that need, good vision. They don't want their eyelid to cover their eyes when they're driving, or surgeons who are operating, or even physicians discussing. I had physicians who patients sitting in front of them, and then suddenly they develop these symptoms. So they can be very annoying and disabling.
Yeah. So we've talked about ocular. There's generalized myasthenia gravis. Are there other important subtypes that really are prominent and seem to be really, really unmet needs?
Yes, so again, you asked me about bulbar symptoms as presentation, respiratory muscles. In certain patients can be a presenting manifestation. These patients end up with the pulmonologist. But in terms of pathophysiology, 80 to 85% of patients with GMG or generalized myasthenia gravis are antibody positive to the acetylcholine receptors, and which really means that close to 20% or less are seronegative. Until MuSK antigen was discovered, its role in maintaining the integrity of the ACH receptor and transmission, adequate neuromuscular transmission for optimal muscle function, antibodies to MuSK were identified, and these are in 7 to 10% of patients who have myasthenia gravis, so which leaves about 10% who are seronegative. So we call them double antibody negative. And although there are newer antibody like LRP4 lipoprotein-related receptor, protein 4, agrin, cortactin, titin, these usually we do not measure. We don't have that much experience. So these are truly seronegative, those remaining 8 to 10% of patients. And this is an unmet need, because for those there is no approved therapy. Not only there's no approved treatment, these patients are misdiagnosed, delayed diagnosis, and can go on for a long period of time, shopping from physician to another until ultimately the diagnosis get made. And unfortunately, they're not invited to be enrolled in clinical trials, and because this is one of the inclusion, they have to be positive for an antibody, and in the real world, because of the delay of the diagnosis, they develop significant weakness that they're not treated for a period of time.
So they have myasthenia gravis, but they don't have the kind of classical antibody showing up positive on a test.
Yes.
So they're seronegative. Are they really seronegative, or is it just that we haven't found the antibody that may actually be interacting with the neuromuscular junction?
So in reality, that proportion is shrinking, but still exists. So maybe 1 to 2% are LRP4, probably some other minor antibody to other antigen, which I mentioned. But the other are seronegative, and likely there would be antibodies that will be discovered. Maybe it has to do with the sensitivity of the assay. Typically we use like a radioimmunoprecipitation assay, but there are newer cell-based assays that increase the sensitivity. So again, it's really the fault, or that there are no sensitive, very sensitive method to detect those antibodies. So for now, they're labeled seronegative.
Yeah, so science has to catch up with these patients.
Yes.
Otherwise, they're still falling through the cracks and having really delayed diagnosis. For our last question, I wanted to turn to a topic that on a poll of our audience before we went live, turned up to be kind of topic number one, which is future, what's in the future of myasthenia gravis. So kind of given the new therapies, what have our treatment goals changed? Should our treatment goals change? What should they be? And maybe as part of that, are there still things that are really critically important that we don't know, that we need more research on?
Yes. So again, of course, thymectomy in younger individual, definitely anyone with thymoma or young individual with thymic hyperplasia and AChR antibody positive play an important role. Of course, when you ask me about different types, I need to mention about different pathophysiology. The MuSK antibody, myasthenia have a different presentation, younger female with predominant bulbar manifestation. Some of them may have even tongue atrophy and the facial muscle atrophy and weakness, look like patient with ALS or motor neuron disease. They can present acutely with respiratory symptom. They can present with neck muscle weakness. But in terms of treatment, so we use steroids, immunosuppressive medication, but more in the last decade, and now really there is a crowding of newer treatment that's really needed is what's called targeted immunotherapy. Okay. So understanding the pathophysiology of myasthenia in terms of what do those antibodies do and what's the mechanism, starting from the original B and T cells and then the production of those antibody, activation of complement, simplification and damage to the postsynaptic neuromuscular membrane, knowledge of the neonatal FC receptors as far as salvaging and the recycling IgG, endogenous IgG or pathogenic IgG. Those therapy have been really quite a breakthrough for patients. Most of those are approved for AChR, antibody-positive myasthenia. Some newer therapy is approved for that smaller subpopulation of MuSK myasthenia. So really the goal, in going back to your question, is rapid symptom control as early as possible. This is one of the issues, the old class immunosuppressive medication. It takes time for them to work. What we call minimal symptom expression, which is really important, which we can measure on a scale called the Myasthenia Gravis Activity of Daily Living, and the minimalist side effect or good tolerability. So you want a treatment that helps but does not give you side effects. So that's one of the issues with corticosteroids. They work, but you cannot keep the patient for a longer period of time because, these patients get significant weight gain, diabetes, other complications. Elderly individuals get, vertebral body fractures, osteoporosis, few other things. So again, you want a medication that works quickly, effectively, powerful, with the least possible side effects.
Yeah, because it's a chronic indication, and the treatment will be chronic, and so any side effects like those you mentioned with steroids will also kind of follow that patient throughout their life. Yeah. It's really remarkable to listen to clinicians who treat patients, and then also because they are clinicians have done research in order to advance the science and in order to improve treatments. I know that is very much part of your work and legacy, and I wonder if we could end with a little bit of personal history. How did you get started in research?
Yeah, so again, I've in my clinical practice seen significant number of myasthenia, mainly referral, different presentations, many misdiagnosed, many not treated well because of delayed diagnosis or wrong treatment, where patient present with tremendous side effect. And again, it was an art how to treat those patients. It's an art how to use steroids in those patients, how to use combination therapy, how to use rescue treatment, how to counsel patients, because it can be like this, very quick, that they decompensate, need to go to the emergency room, can be life-threatening. And so educate other colleagues, ER doctor, pulmonologists, surgeons, anesthesiologists, which are really very important. And then, I started to become involved in clinical trials of myasthenia. Was also an investigator, in a study that was led by Dr. Gil Wolf, which was a landmark study about the extended transsternal thymectomy for non-thymomatous generalized myasthenia gravis that proved beyond doubt the efficacy of thymectomy. These were patients between the age of 18 and 65, have to be antibody positive, they don't have to have thymoma. And they look at the QMG, which is quantitative myasthenia gravis score, like a time-weighted change, as well as dosage of prednisone, immunosuppressive medications, and hospital admission, which all favored thymectomy. So now it's now one of the standard of care for, again, specific patient population. And then clinical trials, many that failed initially, but more recent ones since 2017 that really remarkably are working well. Complement blockers, FcRn blockers. Again, on the horizon, newer treatment that target different aspects of the complement pathway, whether the alternate pathway or not even C5, but the earlier stage. Mode of administration is very important, and frequency. which are really important. And again, many of those trials, I'm involved in those.
Yeah, no, and thank you. Thank you for everything that you've done to kind of really advance the science for your patients. So just in terms of this discussion, I wanted to thank you. I wanted to thank the audience. We actually covered, I think, one of the big topics that you guys were interested in, which was, research and how Dr. Beydoun got started there. And just in closing, again, I wanted to thank you for everything that you've done over your career. I've known you for many decades as one of the most important researchers in the United States. But then thank you also for spending some time with us today here at AANEM to discuss the history of myasthenia gravis, which you do so eloquently, and trace the trajectory from what sounds like a really tough beginning, where you said the fatality rate was so high, maybe 100%, to where we are today, where we have even new treatment goals. And thank you all for joining us. Hope to see you again at a future broadcast.
Thank you so much.
Yeah, thanks, Dr.
Enjoyed the
Beydoun.
discussion.